Welcome to Smart Life. I'm Dr. Georgi Brusavanik, minimally invasive spine surgeon, and we have my colleague with us, Dr. Jose Mena. Dr. Mena, straight to the point. Patients with back pain, patients with neck pain, it's always a good idea to try conservative care. It's always a good idea to avoid surgery. What can we expect as far as the realistic, reasonable options?
Realistically, for spine surgery, for conservative care to avoid spine surgery, most of the patients, as we know, they should respond to conservative care, and we should be avoiding surgery in the vast majority of the patients. Traditionally, we go through a systematic or stepwise fashion in order to treat this type of patients. So normally, main treatment is to start them on a physical therapy program with the goal of getting a good core strengthening so the patients can learn the proper exercises and the proper techniques in order to stabilize the core and eventually do those exercises on a regular basis. Most of the patients, we know that they're going to fall into this category and they should respond really well with this. Some of the patients, they might not, and that's when we started thinking of getting advanced imaging such as MRI for the most part, or CT scans, or both. And those patients, we start to plan what we call interventional spine procedures. So those are what we call epidural injections, sacroiliac joint injection, facet joint injections, and so forth. Most of the patients, they should respond to this type of treatments, and we normally recommend patients to continue doing the core strengthening program that they were previously learned through physical therapy, and they should be able to advance and progress and eventually get better over time. Of course, there's a subset of patients that they don't respond, and those are the patients that eventually we send to someone like you for more for a surgical route and more aggressive treatments. But for the most part, that's the traditional way that we should expect. And at some point during that that treatment algorithm, patients should respond, and most of them they should respond to non-invasive, purely exercise program.
I hear about so many conservative approach for patients with back and neck pain. And something that I've been hearing over the past 5 years is the use of ozone. Could you comment on the ethics, the science behind it, and in your experience, how effective is that?
Ozone therapy basically is a procedure that is being done minimally invasive interventionally. It's done through the aid of X-ray guidance. So basically, it's a needle that is being placed inside the disc, and normally ozone or O3 is being applied. And basically what we're doing, or the intention of the procedure, is to kind of disintegrate the disc that is causing the patient's pain. Unfortunately, here in the States, it's a non-FDA treatment. It's very widely used in Europe, but not here in the United States. So some patients, they come to the office asking about ozone therapy. At least I don't offer this. And the data is not greatly available here in the States to support the ozone therapy for its use.
Okay. Now, what about something known as a trigger point injections? Another thing that I commonly hear from patients when they come to my office, oh, I've had many injections. What have you tried? I've had trigger point injections. In fact, I come and I get them all the time. What do you think about that approach?
Trigger point injection, basically, what it stands basically is that an injection is being done into the muscle, an area in the muscle that is being tendered. To be quite honest, the evidence is very, very limited for trigger point injections. Most of the time, what's going on is something deep in the spine, in this case, that might be triggering the muscle to spasm. So what you're doing with it, or you're accomplishing with a trigger point injection for the most part, is that you're treating the consequence of the problem. You're not treating the root of the problem. So if you start getting, and I'm talking about patients that if they're getting trigger points after trigger points after trigger points, normally there's something wrong going on. So they should be looking now. We're asking the physician to look mainly on what's actually why the muscles are getting into spasm. Maybe it might be a joint memory arthritic, might be a disc problem inside the spine. So there might be something going on, and basically we're putting a Band-Aid there rather than actually addressing the root of the problem.
It makes so much sense, particularly with the fact that patients keep having to get more and more of trigger point injections. Okay, so what about stem cell injections? A lot of my patients have been looking for stem cells. I hear from patients who've gone to Mexico, to Thailand, and the saddest part is when I see patients who've been paralyzed due to an accident, trauma, and they're trying to get off the wheelchair and they will do anything. and they go and seek out stem cell injections. Could you comment on the utility of those, please?
All right. Basically, stem cells. The problem with the stem cell is still in the baby steps, at least for spine care. The studies are so far they don't show where you should be harvesting the stem cell, if it's from the same body or from fat, from placental tissue, from nuttic tissue. So still that's on debate and still widely under investigation or experimental processes. At least I tell the patients that they should look at significant amount of data before going into, if they're looking into stem cell therapy. So that's why it's still not FDA approved, or insurance actually are not covering stem cells for the treatment of actual spinal pain.
Makes sense. Okay, so now what if we get away from injections and look at more things that a patient can do? What do you think about the utility of the inversion table?
Well, I tell the patients about inversion table whenever they ask me, what about inversion table? Can I use it? So I will tell them, if you already have the inversion table at home, fine, so you can use it. Unfortunately, what I tell the patients is that we don't leave in the moon. So when you do inversion table, you're nicely decompressing the spine. But once you start putting the feet back into the ground, gravity will pull everything down. And actually, the symptoms eventually are going to come back. So I would tell the patient, don't waste their money if they haven't done or they haven't purchased an inversion table, because it's more of a temporary solution for some kind of a temporary relief rather than actually treating the actual sort of the problem. So that's what I tell them. That's my 2 cents there on the inversion table. So if you already don't have it, don't invest your money. But if you have it, then fine, you can use it, but keeping in mind that that's actually just not going to solve your problem. So in reality, if it's going to work, it's going to work temporarily, but not long term.
What do you say to a patient who has tried it all, but the list of things that they've tried includes things that are perhaps less common, have less research behind them, or things that just straight don't work? How do we find out what's actually going on? How do we get to diagnosis on these patients?
True. Actually, the diagnosis will start getting a good history and physical examination. For the most part, you should be able to kind of have a very concrete idea with a good physical examination. And then you will couple that with the imaging study. So the imaging should actually help you rule out what you're thinking on physical examination. And unfortunately, gold standard of care actually is putting an injection and actually the patient getting relief from the actual source of pain. Normally, I would go more of a traditional way, traditional type of treatment, good history, good physical examination, getting to more or less what's going on there, treat the patient accordingly with an exercise program. If that fails, then we start moving the algorithm, getting MRIs, doing injections, and so forth, and eventually getting back and rounding that up with a good exercise program.
Brilliant. I couldn't agree with you more. It has to start with a diagnosis. Thank you, Dr. Mena. This was very helpful.
Thank you so much.